You're listening to Healthcare Now Radio. Stand by for This Just In, the latest in healthcare innovation and technology trends with your HIT advisor, Justin Barnes.
Thank you, everybody, and tuning back into us. And I certainly want to thank everybody from Business Radio X who's producing this live HIMSS19 segment of This Just In Radio show. I'm your host, Justin Barnes. My next guest is the one and only, infamous...
What's up, my man?
Aneesh Chopra. How are you, my friend?
I am awesome. Thanks for having me.
Always, my friend. Pink socks?
We in spirit. I didn't physically wear my pink socks, but I'm with spirit in the family. Dude,
Amen.
What a big day, 2 days,
Amen.
Decade.
Yes.
It's a lot going on, man.
It's awesome. Healthcare's awesome.
It's going to be great for families, and I'm excited about where we're going. So talk to me. Where do we want to start?
I actually got something really cool for you.
Yeah.
Just came out a couple weeks ago. I'm chairman of a health organization in Georgia, and we actually just got, so part of my world is insurance now. It's because I'm trying to merge all this great innovation, technology, with care providers, with insurers. So I actually just got offered a 20 to 30% reduction. I have a think tank tomorrow that I'm actually discussing this in, but I want to mention it to you because you always think way ahead of the curve.
Yeah,
I love
let's do it.
So actually 20 to 30%, depending upon the employee or the individual. It goes individuals and in companies. But 20 to 30% reduction for our care strategy based on a DPC model, direct primary care.
Oh, really?
But with all the specialists wrapped around it.
Nice.
And then integrated insurance, with the insurance giving us a care credit of 20 to 30% because of our care model using technology and innovation and the right-minded thinkers in the doctors.
I love it.
Yeah.
I do think the self-insured employer market is ready to benefit from this move to value,
Exactly.
and so you're involved in this.
Yes, that's my.
So let's connect that to the regulatory world.
Love it.
So we regulated EHRs, so doctors and hospitals, and so we have ostensibly now a modernized internet-based method of accessing health records and moving it from a practice to an app on the iPhone. Yesterday, CMS said health plans that work on behalf of the government must similarly provide an open, standards-based API so that the data they collect, mostly claims, will be available to the population they serve. And this is the first time a health plan is going to be faced with a kind of an obligation around open APIs. It is compelling the industry to standardize. And what I would suggest in your model is that we staple Appendix A to your contract that says that the employers who want to benefit from this new model have the insurance company that provides the TPA claims administration also offer an open API so that consumers can have access to their information. And you could be the conduit by which that information, and organize it so that the folks in DPC, obviously, they're the quarterback.
Yes.
That's the power of the DPC model. But if they do need a specialist, being able to organize the information and bring that information back. And so that Appendix A for employers in models like the one you're launching is a great extension of this new thrust in open data.
Excellent. Where do I find that? Where would I?
So the rule here's how I would suggest. We have to write Appendix A. Okay. That hasn't been written as an industry yet.
Right.
The Carin Alliance at CARIN Alliance.com. Okay. We've got half a dozen health plans to voluntarily agree on a technical data model for what does it mean to give a patient access to their claims data via an open API.
Yep.
So we could certainly, your brain power on that would be useful. And then an Appendix A would be to say reference that data model and make that the one that we make available. So we're geeking out a little bit, but it says this creativity that we've got.
That's what I love.
The key is bending that healthcare cost curve so that we don't take the 18, 19, 20% of GDP to 25.
Right. That's exactly right.
Your self-insured employer model moves that in the other direction, but you need information to be effective in making sure the model works. So
Very
God
true.
bless.
I love it. So we'll take a step back just so we catch everybody up because we did geek out a little bit there.
Yes.
But what do you, first of all,
how
many HIMSS have you been to? Is this your 7th, 10th, 15th?
Oh, it's probably at
20th?
least 7. I don't know. I mostly came when I was in government, so I hadn't been prior to that. and I've been in government probably 8 years, and then you go years after that. So here we are. Let's call it 10 years for fun.
Awesome. What are your goals for the next couple of days?
Look, my number one goal at HIMSS, which I think HIMSS is designed for, is collaboration.
Yeah.
This is where people from the industry get to know each other, reconnect, and what I want to do is go beyond the social aspect of the connection, but we've been organizing roundtables throughout HIMSS. We had one earlier today with this idea of consumer-directed exchange. The Argonaut Project, as you know, the HL7 community. We're going to be gathering at 3 o'clock this afternoon, I think in 310A or B, if anybody wants to join.
Excellent.
And the premise is that let's turn the convening power of HIMSS into an actionable, active collaboration model. And so that convening to collaboration, that's the spirit, and that's what we love of HIMSS. And, I'm sure the booths are wonderful, and I'll do my best to make my way around it.
I know.
But maybe this is not the highest value of time. But anyway, yes.
No, I love it. So what trends or healthcare trends or IT trends are you seeing in the industry right now that you're working on, you're focused on?
My number one goal, the big trend, is that we will start to see health information fiduciaries emerge. So as we have consumer-directed exchange come to life, and Apple Health is a beautiful manifestation of that, we also will start to see, now the pressure's on the regulators saying gas pedal, more consumer-directed exchange. While there are apps, and I think that there'll be better apps with better features, I believe they're going to link to something like your DPC model or something that says, just like you thought of Fidelity and Vanguard when you took your pension plan and made it a 401k, I think there's going to be something similar with managing your health. And so someone who's accountable to the patient, who is giving them advice on the best interests of the patient, that to me feels like the next frontier. Now, will they use a lot of the plumbing and the technology here to make it successful, to do that? Sure. But ultimately, it's about there being a new service on the menu that is, entrust me with your data, and I'll give you objective advice to be in your best interest, not those of my sponsor or whatever.
Sure.
And that's the spirit of what I'm pushing for generally in the industry.
So, in that vein, what are 2 or 3 best practices that you would say or offer to people to help navigate that or engage that in some capacity?
Well, my number one, so in my example, I would view the work you're doing without knowing other than the 2 sentences of what you said. You're effectively operating as a health information fiduciary. You are organizing the delivery of care.
Yes.
Presumably the employers who sign up with you are sharing the claims data. So you've got some history and understanding about the problems for the patients. And then you're building up more decision support. And you may choose to have the quarterback, the DPC doc, be the arm of change. Or you may also, start to communicate with patients and families. The caregivers are, I think, the unsung heroes here. And they may be another point of activation. So point number one for me is, let's build on what's working. Those who are moving to value-based care are natural health information fiduciaries, point one. Point two, we really need to have this, the HIE of one in terms of what are the kinds of things you'd like to say. So if you said to me, my mom and dad are both on Medicare, I've got access to their Blue Button file. How many questions about their how many questions are in the public source, in the open source, that I could help answer my parents? Hey, based on your data feed, you'd be a great candidate for this DPC program. You'd be a great candidate for diabetes prevention. Or have you thought about this back pain you have? You might want to do a shared decision making consult. So there's a menu of these sort of. How do you use the data now that it's open? And that's what I think that this wave is going to be about. So step one, build off of value-based care. Step two, build a library of queries you could go when you start to activate patients so they can help answer whether they're getting the right care or the care that they shouldn't be getting as they navigate the system.
That's excellent. So now, thinking ahead a little bit, a couple years, say 3 years out. What do you think we should be, or what do you see we should be thinking about as an industry regarding a trend, or basically what we have to navigate? Because right now, HIMSS is a lot about here and now.
Yes.
We do talk about some AI, and there's some stuff today, and there's some stuff tomorrow. But what do you see in 3 years from now that we didn't think about today?
Well, I think people are thinking about it, but they're going to scale. And that is, in general, we have tried every policy intervention to fix healthcare. We've got some state-run, there's some federal programs, there's insurance-led, but we really haven't built a model that's powered by patients and the decision support around patients. So my view is if you carry what I just said, the library of queries, the role of value-based care, I believe there's going to be a new actor organizing the delivery of care for patients. And that, to me, that's the big opportunity that we haven't quite sorted out. So CMS launches the eMedicare mobile app, and it says, hey, by the way, you're eligible for an annual wellness visit. Well, in the app, they say, by the way, you get a personalized care plan. Well, how many caregivers, my mom and dad, if they've had the wellness visit, I don't know what their care plan is. Maybe I should help them make sure they stay compliant with the plan. How easy is it to get? That's not available to me on Apple Health. It's not something that's standardized in the open API.
Right.
How do we get that? So I think we're going to need, we need to start putting together the service delivery models that take advantage of this information optimized for the patient. And I don't know what that's going to look like, the form and factor, but I think in the next 2 or 3 years, there'll be a lot more of those than just the traditional extensions of the doctor's office, extensions of the insurance company.
Yeah, no, I love that, and I agree with that completely. We need to start to be thinking more in that direction for sure. What do you think about the information blocking rule that came out, or the interoperability rule, I'd like to say?
So I would say 3 things. Number one, it does create a dynamically generated floor, meaning we got to get the entire health record in a machine-readable format available to an app of a consumer's choice. And the floor is going to raise, the rule basically says we're going to be ratcheting this thing up until we get to the full health record.
Yep.
Point 1, we're on a journey to give it free to the patient. 2, we absolutely have to find a way to put the insurance industry on notice that they're next. So we haven't done anything to get the insurance data out. We're going to have to do that. CMS says that loud and clear. But then I think this third provision on information blocking, this opens up a new idea. And I'm going to be toying with this. We're going to trial it on this radio show.
There you go.
Net neutrality for healthcare data. And here's what that means. If you're a data holder, whether you're a hospital system or you are the EHR, you're allowed to charge reasonable fees to recoup the costs of accessing the data. So if, not to the patient, but if you wanted to share it with the insurance companies or whomever else. So what is reasonable fee? And it just introduces the idea of a value-added fee. You could compete on value-added services, but you can't monopolize the access to the data. So in a way, that was our net neutrality construct, which is the base utility, the internet infrastructure, doesn't matter who your cable company is, that is an open resource. And if the cable company also wants to do predictive modeling for, fall risk, well, great, they can build that prediction model and fall risk, but they'll compete like everybody else on the use of that data. They couldn't take advantage of their position of access to the data to be uniquely positioned to launch their own apps. It's a net neutrality for healthcare data, and I do believe that will have the most economic impact. This entire floor is powered by organizations that have figured out different pieces and parts of the business model on data, and this rule has just created a new regulatory edge on exactly what that looks like. So that, I think, is the sleeper story of the HIMSS and the information blocking rule. How we do reasonable fees and value-added fees to drive true innovation in the delivery system.
Is that going to? Do you feel that's enabled with the regulation right now? Is it proposed?
Yeah, these things are all going to be litigated or gone through some complaint process. But even the notion in the preamble of the rule that there's this idea that there are costs to sharing data, but they should be priced at marginal cost or recoup, a la utility-style regulation, cable net neutrality-style regulation, and let the value-added services compete in an open market. That's a profound idea captured in the rulemaking. And since it's tethered to the 21st Century Cures Act, massively bipartisan, I think it sticks. I think it sticks.
I love it. Actually, I have Elise Sweeney Anthony on my show at 3:50 today, talking about the new rule.
Amen.
So, love it.
Thank you, brother.
Well, in closing, one more question for you.
Yeah, of course.
Crystal ball.
Yeah.
Or not even crystal ball. Wishing ball. Whatever.
Wishing ball. Dreams. Dream a big dream.
If we could have, if there's one piece of policy we still have to figure out on Capitol Hill, and we had bipartisan support for it, what do you feel that we need? I know I'm throwing you a curveball, but What do you think we really need to help accelerate what we're trying to work on and achieve in this country?
So there is this challenge, which is we do still have the conundrum of patient identity in the digital era.
Very true.
So Peter Levin, the father of Blue Button,
Yep.
We have the opportunity to allow consumers to log into portals and download their files. But if I took your portal credentials, Justin,
Yeah.
and I log in and I pull down your Blue Button file, not so great. And we understand the problem. There are many technical pathways, but this is bigger than technology. We're going to have to sort out identity, digital identity in the era of the internet economy, especially in the regulated sectors. And so, to me, whether it's patient ID, patient matching, and patient authorization, there's something about how we get you on your smartphone connected to the doctors, hospitals, insurance companies that you trust, and pulling the information that's meant for you out seamlessly.
Right.
The technical piece is there on once you're connected, you can download those things. That's what we've got with the Fire API.
Yep.
But the front door has still some work to do on identity and how we sort that out. So that to me is an issue. It may require more congressional action on broader privacy and security rules around the internet economy, and we'll kind of take our temperature on what that looks like in the coming weeks.
Awesome. I love it, my friend. Thank you,
sir.
Anish, as always, brother.
My
Take care.
pleasure.
Thank you. Have a
Cheers.
great rest of the conference.
All right, you too.
Thank you. Thank you very much, everybody. Appreciate you sticking with us. There's about 30,000 people listening to us right now. So, Dr. Jethwani, true pleasure from Partners Healthcare, but also you're from the Healthcare Pivot or Partners Healthcare Pivot Labs. But you're always a tremendous guest, not only on the radio show, but with our think tank. So thank you very much.
Thank you.
And we'll actually, we start at 6:30 in the morning. I know it's going to be very early, but you'll be done by 8:30. So, anyhow, but thank you very much for joining us today. So, you always have a great perspective, very innovative. You always share phenomenal best practices in our think tank. But what to start off, what are some of the trends that you're seeing out there in healthcare and health IT that you want to talk about?
All right. First of all, thank you for having me on the show. It's always really fun to be here. It's a lot of mental exercise. I'm always nervous about whether I'm going to be good enough for you or not.
Yeah, right.
So,
Awesome.
It's great. So healthcare and health IT. Let me start with the trend in healthcare, which everyone's seeing, but I kind of just want to call it out, which is all of the interesting consolidations we're seeing outside, right? So, CVS, Aetna, the Amazon consolidation with Berkshire, all of those really interesting partnerships and consolidations are I think, going to change the landscape for healthcare in the next 5 to 6 years, and I think that's worth watching. So every time in boardrooms also, I sort of bring it up for my executives and be like, don't forget, CVS Aetna's together now. What's that going to look like?
Right.
So that's one that I think we should always keep on our ante if we aren't already. The second trend, I think, again, sticking to healthcare, not health IT as much, is the trend for consumerism. So speaking from a provider organization standpoint, we are actually seeing our patients demand of us that we actually move into the 21st century finally, and they ask us questions around, if I can book a restaurant table on Open Table, why can't I just book, why do I have to be on the phone for 27 minutes to book an appointment? And then why is the appointment 4 weeks later? Right?
Yes, good point.
So that's a trend, and that's growing, and actually that pain is being felt more and more every single day as a provider. And then in terms of health IT, a trend that I'm seeing a lot, and literally probably get a phone call from a community hospital every week on this, and it's the buzzword of the year, which is AI.
Yes.
So and specifically, how can hospitals make better use of all of this in money that they've invested in EMRs to make sense out of the data and to be intelligent about it? And that's a trend that I'm seeing. Now, whether that's a bubble or not, I'm not sure. The jury's still out. But that's definitely a trend of it's catching everyone's fascination, and it'll be interesting to see what happens in 3 to 5 years with that.
So talk about some of the best practices on navigating those. So what are, say, 2 or 3 best practices for people to successfully navigate those trends?
So starting with AI, I think a lot of people are very quick to jump into using AI for clinical decision-making and clinical programs. I think it's a miss. I think that there's probably lower-hanging opportunity in the operational side of healthcare with AI.
Yes.
And not a lot of people are focusing on that, but the data is a little bit cleaner. The data, the mistakes are less expensive,
right? Very
and
true.
the stakeholders are a little bit more involved. Being able to save the time of a front desk person in bringing her down from 30 minutes to 10 minutes in booking an appointment is actually a great savings that no one's really focused on. And so I think the more people think about focusing on operational versus clinical, I think that'll be really interesting. The second area I think that's really interesting in AI is imaging. There's more evidence out there for imaging-based AI programs than like clinical EMR-based AI programs. And then speaking as a physician, we entered this data into the medical records, and I know how dirty that data is, right?
Yeah.
And so I'm scared when people tell me that they're going to make intelligent decisions based on that data.
About that data, right?
So I feel like there needs to be like a mass cleanup project where we all need to come in together and decide that we're going to use this data a little bit more. We're going to input this data more thoughtfully. But till then, I think that's a very high bar to climb. And organizations are spending way too much money on trying to climb that, and I think that they're missing out on key opportunities.
No, that's fantastic. Spend a second on you shared in the last think tank, you shared some great stats around a research study that you did on virtual care. On basically, you put it out there to your population, said, would you like to access your if a doctor had access to your medical records, if they did not have access to medical records, this is all through virtual care. Talk about that for a moment, if you would, if you have some of those stats off the top of your head. I didn't tell you to talk about that, but that was very impactful to me. I talk about that now probably on a weekly basis in different speeches and all that.
Yeah, so this is
and I give you the credit. It's amazing.
No, thank you. This is a marketing survey that we had done 10 years apart in 2005, 2015. And in 2005, we asked people what is the most important thing for you as you're considering how to pick your PCP? And, an overwhelming majority of people, or close to 80% people said that brand is one of the most important things. That they want their physician to be a really good physician, right? Really well trained, coming from a credible school, etc. We repeated the survey in 2015, and only about 43% people said brand. A bigger number of people actually said convenience. And so at Harvard, we're looking at ourselves and we're like, we have 13 Harvard-affiliated hospitals, and now people don't care about brand? What are we going to do, right?
Right?
And so if convenience is now becoming a bigger issue, then we need to really change our business model and really be able to figure out how do we compete on convenience, because guess what? CVS Minute Clinic is way more convenient than any of our organizations,
Very
right?
true.
So how do we get there? And I think that's where we really see the opportunity in digital. And it's not an opportunity anymore. It's a mandate.
Yep. It's awesome. No, I think that's a big thing. So how are you guys what changes have you made to promote convenience over brand? And
we're doing a number of things, and I think a lot of other organizations, and I give credit to a lot of other organizations who've spearheaded in this space much more. Last year we launched our first virtual urgent care, right? So right now, any patient who is insured by our payer organization, Always Health Partners, has the ability to seek urgent care via virtual means. So it's all video and phone enabled. That's now currently covering about over 200,000 lives. So that's a big initiative that was launched in June. We are also trying to once this is successful, we're going to roll it out to every single patient at Partners. So that's going to be one thing. We're launching several AI-based programs specifically on the operational efficiency side. We're thinking about how to make better decisions about when to discharge people. We're making better decisions around how to treat them once they're discharged. We're making better decisions based on whether they're a high risk for coming back within 30 days or not. We're also trying to do other operational efficiency gains in terms of better referrals, right? When should a PCP refer a patient to a specialist? Can we use AI to start informing some of those things? And then also using digital wearables to be able to predict when someone's disease is going to get bad. So if I can give you a Fitbit as a COPD patient, and I can watch your Fitbit data and predict a week before you become really sick that you're going to get sick, right? Now that's a game changer, because then I can intervene and I can prevent a 2 to 3 day rehospitalization, which is really expensive.
That's fantastic. I love it. So now, thinking beyond today, we spend a lot of time here at HIMSS. We're seeing what's here now and what's coming in 2019, 2020. But thinking about 2022, what do we need to be looking at on the horizon to be able to thrive in the future or be ready for where we're going? What do you think?
I think the business models that'll exist in 2022 don't exist today. So if you are a vendor, you probably want to think beyond the business models or the constraints of the business models that you're trying to cater to today. When your pharmacy becomes your insurer,
right,
a lot is up for grabs. Just think about that. So I always encourage companies to sort of figure out a way to do the right thing and don't be constrained with the business models that exist today. It's going to change. That's one thing. The second thing I would say is in terms of trends coming up, there is a big opportunity in zero interface interventions, right? So voice is becoming a big thing, and I have mixed feelings about it personally, but I think there's an opportunity there. I think there's a pretty big market that's going to open up once voice is figured out, and Amazon is going to figure it out. We're not going to figure it out.
Right.
And then from a clinical delivery system perspective, in 3 to 5 years, I think we need to be prepared to give up the routine things that we see our patients for. I don't think provider organizations are going to be in that business anymore. I think we need to specialize, and we need to be able to provide chronic, complex care that others cannot provide. And I think that's just going to happen.
Yeah, and the last point, actually the last 2 points, actually all those I agree with, but I'm on the last point, I'm a chairman of a health organization in Georgia that actually has already moved well in that direction. So we deploy a very vast amount of DPC doctors. They practice on the top of their license, and so now the only thing we send to a specialist is a complex case, because our doctors can handle a significant majority of the 90% of care, but you need surgery or you need a knee replaced. Those are all the things, and I have full transparency, and I'll talk about this a little bit in the think tank tomorrow, is we already know that knee is going to cost $4,200, not $12,000, but $4,200. Our colonoscopy is $1,250, and we publish our prices. And that's a game changer in a lot of ways, from how people are practicing, how patients are flowing, where they're going for care, but we have better outcomes.
And I mean, I think the key philosophy for us in our organization is right patient, right time, right place.
Yes.
So if you're a patient that can be seen in a community hospital, you should not be seen at an academic medical center. If you're a person that needs to be seen today, you should not be seen tomorrow, right?
Correct.
And so how do we get to see you in the right place at the right time with the right expertise, and how do we strive towards that using digital as an enabler?
Yep. And I think the last part you brought up on the voice side, I'm very bullish on it. I agree Apple will solve some of those, certainly the bigger complex pieces, but I do believe in, as we came up in the think tank, voice first, but not voice only. And I think, I think really with the consumerism, patient engagement, patient education, I think about my own example. I did have a colonoscopy a couple of years ago. I don't remember a darn thing that gastro doctor told me after, because I was still coming out from the drugs. And I couldn't believe it. But he rattled off all these great notes. Phenomenal doctor. Thankfully, everything was good, so I didn't have to remember anything. But what happens if it wasn't great? And he gave me this advice. You got to do this in this treatment protocol, and I don't remember a word you said. I can barely remember his face. And so, I was still under, my anesthesia. So, anyhow, it's I do see, and I think of Louise, and if you remember from the think tank, Dr. Jack is doing actually in your backyard up there in Boston.
We had a really interesting experiment. This was several years ago, more than 10 years ago, where we used avatar technology for discharge planning. And so we did a control trial where half the group got a real nurse to do discharge planning, and the other half got an avatar on a screen. And statistically significant improvements in retention with the avatar, not with the nurse. And so when you ask the patients why that's the case, they're like, "Oh, because I was able to rewind her 4 times, but I can't ask a real person to repeat something 4 times because I'm embarrassed, right?"
Correct. That's
so
psychological point.
We can get better outcomes with So it's
very cool. Well, thank you, Kamal. And for everyone listening, thank you for joining us today. And please tune in weekdays at 2:30 p.m. Eastern, 11:30 a.m. Pacific. As always, you can track me on Twitter at HIT Advisor, and you use the hashtag #ThisJustIn so you can respond to your comments from the show. In addition, all my content's always posted on my website at justinbarnes.com. Thanks, everyone. Have a terrific week.